ER for 8 minutes, immediately taken up to surgery, and those golden hour minutes make a difference. They make a difference. You know that working here. And that patient had a great outcome. Where before they would have had to go back and be re-imaged, they would have been exposed to more x-rays and things like these are kids. So we're flying these images back and forth. That's one component of it. But now what we can do is we can hook up over video, and that physician can get the support they need, that ER can get the support they need. They can make a logical decision of what to do with that patient, where it needs to go. And so between the two, that patient's going to be better taken care of. And guess what? Sometimes they decide not to transport that patient. They say, wait a second, you can treat that patient in your hospital and not the costs and everything else, and that patient can stay there and still receive the same quality care. That's what this is about. This is cool technology. This is great. It's about the relationships. And we have been doing relationships for 10 years now. So we've got the high-def camera, and you can see wounds, you can see close-ups. We use them in our nurseries whenever we need to transport babies. So we're comparing apples to apples. We know what the patients are we're getting, and so they can be treated as well. If this isn't good enough, the other thing that we can do is we have put on these. Get my computer way down. It's behind you. Oh, it is. Okay, there it is. Sorry. We put peripherals. So now we have a general exam ENT scope that we have connected to all these units with that. So it's a software that's located on your computer. So if I wanted to take an image, I would pull up images. I would pull shoot, and then you're on TV again. But this has a live source. So now you can do detailed images. So if you need to, it's got a general exam scope. So if I needed to see a mole or something like that, you can see how close that gets. You can do, I'm not going to shove this down my throat or whatever, but you can see what's going on. So either you can use it live, just if we were still connected to the capital, you can see it that way. Or with this software, you can hit the button once, freeze it, and now you see I have an image over here. So then you can take images, store them, and then you can show them to whoever that specialist is or whoever you want to share them with later on. Because it's stored on this computer. This computer is just here for connected to your hospital. It doesn't go anywhere. It's not being beamed at the time anywhere. So then you can go and do whatever you need to. You can also take this off, and you can put the ear cover on it, and so you can do the ear exam as well. With this equipment, the way we built it, basically, if there's an orifice, there's a scope you can connect to it. Obviously, you better make sure. Yeah. I'll pass. I thought you feel better already. I'm done. One of the things we learned over the past 10 years with this technology is when you're doing phone communication, and a lot of our physicians go, oh, I can just talk to them on the phone. Well, you can, but you lose 15% of great communication by not seeing what you're also talking about. So this is support for the local areas. It's not just about, the physicians or support people that are off in the distance. This is about for you here in your community and what's best for that patient.
But you can begin to see why the payment redesign is so important, right? I mean, specialist time, if there's not a billable service, it's not something that can be afforded. So it's got to we got to link all this stuff together. It just has to.
So we can flip back and forth between the specialty cameras or the big camera and communicate with who we need to. It doesn't matter. Let me tell you a little bit about this. The cool thing about this project is, yes, you can connect to Texarkana. You can connect to El Dorado. It's not about UAMS. We want to supply as many resources as we can, but we know you have other relationships already. And so we want you to use this for that. Because again, that's where, I talked about patient reform. We have got to be able to move that patient up and down the spectrum of where that patient needs to be and receive the appropriate care. That's what Dr. Ron's talking about. That's the change that we got to think outside the box for. And change is hard. It really is. And we talk about this just like, oh, it's already happening, because we see it and live it and breathe it every day. But it's not. So what we want to do with this middle mile infrastructure is have you dream. It's like, now how can I get connected and better connected of what I want to do what I need to whether it's nursing instructing, SAU could beam in here to the hospital. You could beam into other nursing courses. If you want to see a high-risk OB clinic, call me. I'll let your nursing students see a high-risk OB clinic. So there you go. See, we're hey. So those are the kind of things that we have to do to increase our healthcare workers, to better educate, to better take care of our patients. The other thing I want to briefly show you is this cool stethoscope. I've got software on this laptop. Sometimes it will come on the computers that are connected to the cards or whatever. But this is just a regular digital Bluetooth stethoscope. So, and it has the capability of recording. So whenever I go in and examine a patient, I would listen to that patient, and I've got 12 places on here I can record. So I would just hit record and put it on and listen to my patient just like I normally would or whatever. Well, I've got a software here that I can pull up. It's Zargus for the stethoscope. And I can say, I want to connect up live. If I have a cardiologist on the other end, it'll prompt me, hit my button. I'm going to connect. So now, I've got a green light. So now, this stethoscope is talking to this HIPAA compliant software. If I'm a cardiologist or whoever in Little Rock, it doesn't matter, Little Rock, Texarkana, again, whatever, all I would do is pull the same software up, and I would say, I'd like to listen to that patient too. So I'm going to start a session. And it's going to give me a number, and I would give it to that person. And so all they would do is take their stethoscope and put it in their ears, and they're going to hear exactly what I'm hearing. Whether they're next door to me or if they're 500 miles away from me, because it's all digital. The biggest problem we have with this, I'll tell you, the cardiologists we work with, is they don't know what to do with their hands. Because they put these in their ears, and they're like, well, where do I put this? Just hold your hands, put them in your lap, and listen. And they can still see the patient over video while this is going on. So they can say, direct the scope, move it a little bit over to your left, now let's put it on their back. So they're still seeing that patient, but they're hearing, again, apples to apples. They're hearing exactly what's going on. If the physician isn't available at the time, I mentioned we can record it. You can do the heart recording, and then it gives you a time to go on, and I can say, this was a 45-year-old male, I think I heard left heart, blah, 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 whatever that is. And then I end it, so the comments are also on here. So at 4 o'clock that afternoon, if that's when the physician's available, you can dial up and say, hey, sign on, I want to play this recording for you. Because I'm not sure what that was when I was visiting the patient. It's the same thing that we have. So this is the kind of way that we're moving toward this stuff. It's the AHEX, it's at the hospitals yesterday.
Tell us right now.
Right. What specialties are really active, and how much that is tied to the priorities of individual participating hospitals and medical staffs. We've got Angels, we've got
exactly.
Arkansas City.
Yes, sir.
But what about psychiatry? What about dermatology? What about pediatric support? What about imaging? I mean, is it vary widely?
It does a little bit. You mentioned RSP. We mentioned RSPMI earlier, the mental health services that Medicaid pays for. Right now, everything's driven around, do I get paid to do this?
Right.
But as payment reform comes around and they see the technology, it's becoming cheaper. We have mental health centers all across the state that we go out and certify. So Health Resources of Arkansas, I'll use an example, Brian Colbart, they have like 20 sites that they do telehealth or mental health over. So they just beam in, take care of their patients, do med adjustments, because there's a shortage of child psychiatrists and psychiatrists in general. Well, now we've got ERs that are saying we need mental health coverage because we have those patients laying in our ER. What do I do with them? I have to hold them until I can get them treated. So now they're seeing this opportunity to be able to partner with hospitals, whether it's the community mental health centers, all those guys have this support. So those are the kind of partnerships we're talking about. Children's Hospital, they have a unit in their ER, they have one in their PICU. So if that baby lands, every now and again it lands in their ER, your first concern is, I gotta call the helicopter and get them out of here. But now they've got units, so you can connect and get that other thing. Dermatology really hasn't taken off yet. It is in other states, and we're learning from those guys. Trauma, that's going to be the next biggest probably carryover with this as far as going from SAGE. We cover 41 sites now, which virtual neurology, just like we do here in Magnolia. And I'm very proud of Magnolia. In the past 6 months, with their stroke patients they've had, we've given TPA 50% of them. Y'all, we gave TPA less than 1% across the state before we started this. It is making a difference.
Margaret, you mentioned burns. From see burns?
We do occasionally.
So,
I made a note of that when that came back.
and you talk about that, but what about the educational component that goes along with that? It can be done by this as well. You're never going to replace the on-site stuff you need to do. This, what we're doing today, can't be replaced. But what's important is those connections in between those times is what really is going to make a difference with that.
What about with your cardiology program? You've got cardiologists who come.
Right.
You mentioned Steve Greer, from the Baptist group. I mean, the
And
ability to have
I'd be
that
glad to
connectivity.
I'd be glad to comment on that. We helped Arkansas Heart Hospital. We set them up to go to clinics. I was in contact with a cardiologist friend of mine at Baptist, who they're very interested in their circuit riding clinics that they do. They're going to start doing this. It's going to be very competitive. Now that
Roxanne is very hesitant about this.
it
It is a system that's statewide, it's
Yep.
open and access, right? It's public, it's in the public domain. And so it's really not the proprietary property of any one health system.
Exactly.
Right.
And my job, and I've had the best job, the best 2 years, I'm going to tell you right now. My job has been to support, I've been outreach to support communities just like Magnolia, just like Dumas and that. And when I go out there, we try to put them up with the resources they need, and we always come home first. We always come home first and say, what can we do? Because we were connected or whatever. But the most important part is, what do we do with our communities? Because a lot of times we can't do everything. We have limitations as well. We have a lot of room to grow. We definitely do. But we can't do everything. And we set this up. Dr. Lowry, 10 years ago, said, we want this to be an open highway. We want more on and off ramps. And let the dust settle. But we've got to build this infrastructure, or this would have never happened for us or anybody else.
I'll
So-
give you a quick example of Arkadelphia Hospital Baptist there. They went from a year ago not using in that particular area their interactive video equipment from us training them on using interactive video equipment, them buying 2 extra stethoscopes. Their cardiologists, instead of traveling from Big Baptist down Arkadelphia 3 times a week to see patients, he's able to stay there and see patients using those stats. So we saw no use to significant gain on both sides. So that's just kind of a good, real close example of a hospital. I mean, they took off there in their rural community.
And guess who covers Baptist, Arkadelphia?
UAMS.
We do.
Yeah.
It's relationships, and how we're coming together and how we utilize this. The last thing I want to touch base on very quickly is, they always say there's an app for that. Guess what? There's an app for that. It's called Jabber. It's a Cisco product that this is going to be where we're kind of looking at the last mile, if you will. But we call it the first mile because it's to the patient themselves. That is the first mile that healthcare should always be. And so through this app that I can bring up here, I can dial anywhere I want on our network from this. We're going to have, I think, 5 to 6, maybe even 7 hand surgeons across the state. Here's an example of utilizing this. We're going to carry these with them. They just need to see through this high-def camera what kind of wound it is. Does it need to be transported to a level 1 trauma center? Does it need to go out of state because it needs to be reattached because we can't do that? And so through doing this, all they have to do, this will work for me, is push this button. And that's my office in Little Rock. This is just over regular 3G. They'll call the ER, they'll be on the phone, they won't do this over sound, but they'll call on the phone and they'll say, let me see the image, we'll put it on high def, they can look at it and they can determine where that patient needs to go to get the best appropriate care. This works in my duct line. I would never let Dr. Ron know that I call from my duct line.
You just did.
I take this.
You just did.
I take this with me everywhere I go to test it because we want to make sure that when this has to happen, it can happen.
So So,
We want-
yeah, so what we do is we say, Manley, turn that around, let us see
Yeah.
where you
Anytime you
are.
Mallards.
Are you fishing, are you riding your bike?
Fly fishing, yeah, it's another. But y'all, it's eventually gonna get down to this. This is where it's going. This, if you look at the mobile health stuff or whatever, a little over 2 years ago, I was diagnosed with a type 1 diabetic. I did everything right. I've been training all my life to be a type 1 diabetic. I'm a nurse practitioner. I work out, I do triathlons, but it's still, I still got it. But guess what? This is gonna take care of me one day. With my insulin and the, working with my healthcare providers. I don't need to see my endocrinologist all the time. But I may need to talk to a dietitian. Because I get the wrong stuff. Or I did need to, he did need to know. But this is where it's going. So think about, this is where we are today. But you gotta think about, how am I gonna expand this and leverage this? Because it's gonna make a difference here for Magnolia. It's gonna make a difference here for the students, for the healthcare providers. But biggest of all, it's gonna make a difference for the patients. And that's what we are figuring out. That's why we like our relationship, because we need to figure out what needs to be moved up and down that spectrum, of course, and how to move up and down that spectrum, and a lot of them are fashion that benefits the patients. Do y'all have any questions about any of the? I know everybody's everybody's dealt a little bit in some area.
So this represents tremendous change, and the only hard thing about change is change. This isn't gonna happen overnight, right? But, whether it is, through kind of, really creating an educational continuum and a stabilized system of higher education or the system of healthcare, it requires a different way of thinking. But what the potential for those